Welcome back, everyone. Thank you for joining us for the Med Safety Exchange webinar series, a joint venture by the Institute for Safe Medication Practices Canada and the Canadian Patient Safety Institute. Just a reminder that this webinar will be recorded, and the link to the recording will be posted on the Med Safety Exchange website about a week later. So we do have all the lines muted, and we encourage any questions or comments to be typed to us in the chat box, and then we'll read them out loud at the end of the webinar during the discussion period. Additionally, if you would like a PDF version of the PowerPoint slides, please email us from the Med Safety Exchange website with your request. The purpose of this webinar series is to bridge the silos in healthcare reporting and sharing and provide a platform for us to share and learn from one another to minimize the recurrence of med incidents and optimize med safety in all care sites. For today's overview, this webinar will have one med incident analysis on communication gaps when dosing for high alert medications such as insulin, and an overview of the opioid harm report from CIHI. This will be followed by the observatory with a description of education support for the mandatory ADR-MDI reporting through Vanessa's Law, as well as an update by CPSI. Then we'll finish up with a discussion period where we read out your comments and keep the learning going. Anonymity is still a choice for all those involved in the webinar, so I'll only introduce speakers very briefly, and they can choose to share as much or as little as they'd like about themselves and or their practice site. I'd like to invite the first speaker to present her med incident analysis on the miscommunication of insulin dosing involving correction doses.
Thank you, Ambika, and good afternoon from Prince Edward Island to everyone on the line. My name is Amanda Burke, and I am a drug use evaluation pharmacist with Health PEI. I appreciate this opportunity to share details of a medication incident that occurred in one of Health PEI's acute care facilities involving a patient's insulin correction doses. Considering insulin as such a commonly used high alert medication, we hope that open discussion of details related to this case may help in the prevention of similar incidents for other patients. To start, I will provide some background information that relates to the incident. Computerized provider order entry, or CPOE, including electronic admission medication reconciliation, was implemented in Health PEI's hospitals about 5 years ago. Approximately 2 years ago, insulin correction dosing was fully incorporated into our CPOE system. This work was part of a 3-year diabetes strategy within Health PEI, with one of the goals being to embed best practice guidelines within clinical practice in hospital settings across the province. Education was provided to staff about the rationale for utilizing basal bolus insulin regimes instead of sliding scales. Sliding scale templates within the CPOE system were removed, and emphasis was placed on utilizing correction scales, which were built as templates within prandial insulin orders. There was also education provided about documenting patients' home correction doses into the best possible medication histories. This slide reviews the difference between sliding scales and correction doses of insulin. The use of traditional monotherapy sliding scale insulin is considered a reactive approach to glucose control and is not recommended by clinical practice guidelines. The use of correction insulin doses combined with a basal bolus insulin regimen is preferred. Correction doses are a final insulin adjustment based on the preprandial glucose value, and you can see by the example that although they may resemble a sliding scale on the surface, correction doses are a smaller fine-tuning of the volume of insulin to administer because they are in addition to a scheduled insulin order. A review of administered correction doses and blood glucose trends over a period of time can assist with adjustments of the scheduled prandial doses. The case we are sharing today involved a patient who presented to the emergency department with shortness of breath. Their symptoms improved with ED management, and the patient was discharged home without hospital admission. 4 days later, the patient presented to the ED again and was admitted to hospital. This patient had several previous encounters with the emergency department leading up to the admission. Per usual process, attempts are made to update the BPMH at each new visit, especially if admission to hospital is likely. In this case, the BPMH was updated several days prior to the admission by a pharmacy technician, and it was documented that two sources of information were used: an interview with the patient and the Drug Information System, or DIS, which is the electronic system that collects prescription dispensing information from PEI community pharmacies. On the day of admission, the BPMH was documented as complete by a nurse. There were no significant changes to the more than 20 separate medication orders listed on the BPMH from 4 days prior. The information source documented was the DIS without a patient interview. On the day of the patient's admission to hospital, the electronic BPMH was used for completion of admission medrec by a physician, thereby generating inpatient orders. The admission orders included the patient's usual home insulin regime, which at the time was a basal order of insulin glargine 38 units at bedtime, and 3 prandial orders of the rapid-acting insulin glulisine, 24 units in the morning, 12 units at noon, and 19 units at supper. Each of the prandial insulin orders also included correction doses as at home. The patient's home correction doses did not appear to match the pre-built options in the electronic chart where home meds are documented, and were therefore transcribed into a blank template. This screenshot shows how the morning prandial insulin order was entered, and the order comments section of the order where the correction doses would have been transcribed. On day 2 of the patient's admission, the physician notes referred to the blood glucose running low and the patient being on a diabetic diet. The insulin orders were therefore adjusted. Specifically, the prandial insulin orders were reduced by 6 units for the morning dose and 4 units for the noon and supper doses, as outlined on the slide. The correction doses were not modified at this time. During the next 5 days of the admission, the patient experienced multiple hypoglycemia episodes. A nursing student questioned the correction doses, inquiring why they were higher than usual correction doses. There was documentation in the chart indicating that the patient also stated that an insulin dose was high. This helped prompt a closer review of all the insulin orders. The Diabetes Education Center was consulted, and they provided a copy of the patient's most recent insulin dosage adjustment form for reference. This screenshot is intended to represent a section of the form. The insulin correction doses were presented to the patient with total calculated doses displayed in the correction column, the prandial dose plus the correction dose. This was intended to assist the patient who was visually impaired and avoided the need for them to calculate their dose. The form did not identify that these were total doses. It was discovered that these totaled insulin values had been erroneously entered as the correction doses on the patient's BPMH several days prior to the admission. The confusing orders were not recognized when the BPMH was completed on the day of admission by a nurse, converted to inpatient orders by a physician during the MEDRAC process, and verified by a pharmacist. Upon review of the insulin administrations documented in the electronic MAR, it was identified that the patient received more insulin than intended on several occasions. The recorded insulin correction doses were interpreted in different ways by different staff. Most recognized that they were higher than typical correction doses and interpreted them as sliding scale orders. For example, one of the patient's morning blood glucose readings was 12.4. Based on the order comments, 26 units of insulin were administered. This was 6 units more than intended, as the morning prandial dose had been decreased to 18 units on day 2. Following the correction scale, 2 units would have been added for a total of 20. In this example, the patient was administered 36 units of insulin based on a blood glucose value of 8.7, which was 3 times the intended dose. The dose was calculated based on the prandial order, which had been reduced to 12 units, and the corresponding correction dose, which was documented as 24 units. Fortunately, the patient's hypoglycemia events were managed, and once the correction dose orders were clarified and transcribed correctly, the patient had no further episodes in the following days. There was open communication with the family about the incident, and they expressed a strong desire to share the learnings of the case with others. During the assessment, the challenge of incorporating patient-specific correction doses into an electronic entry in our CPOE system was recognized as a contributing factor. The Provincial Diabetes Program has informed their staff of the incident, and educators no longer document the total correction dose in the way described. It was identified that transcribing customized correction dosing into electronic orders can be risky. For this reason, the CPOE system has common correction scales pre-built. The Diabetes Education Center insulin dosing forms include a notation of whether the correction doses are low, medium, or high, and these align with the pre-built templates in our CPOE system, which should help reduce the need for transcription. Additional education has been provided to acute care nursing staff and pharmacy technicians to remind them of this. Despite multiple healthcare providers having reviewed the insulin orders, including several different staff members from pharmacy, nursing, and medicine, the confusing way in which the correction doses were documented in the order comments was not clarified. This case highlights the importance of reviewing the order comments section of electronic medication orders, where additional information pertaining to the order may be found. In some cases, this information is free-texted, which can increase the risk of error. The information contained in order comments is not as visible in some parts of the electronic chart as traditional medication order fields, such as drug, dose, or frequency. For example, the screenshot shows our CPOE electronic MedRec screen. The order comments do not automatically display and are only visible if the user hovers over the order. In this case, it is possible that the prescriber did not see the correction doses recorded in the order comments during the MedRec process. The case also highlights the importance of a patient interview during the BPMH. Potentially, the confusing insulin entry in the BPMH would have been identified if the patient or caregiver were re-interviewed as part of the BPMH process on the day of admission. As part of the assessment, a summary of the incident and learnings were communicated throughout the organization in a safer practice notice. This slide lists several recommendations that came out of the incident assessment. As you can see, some of the work is still ongoing and included submitting the incident to ISMP Canada, and we are open to considering any recommendations that come out of this process. In closing, two obvious points that I think warrant mentioning. This case is a good example of how healthcare teams benefit from different perspectives when trying to solve drug-related problems. We are all aware that medication management is complicated, and certainly diabetes management is becoming increasingly complex. One person does not have all the answers. The case also demonstrates the value of having students on our teams actively participating in patient care, and it affirms the importance of involving patients, heeding their questions, and where possible, engaging them in aspects of medication safety. On behalf of Health PEI, I would like to thank ISMP Canada for the invitation to share aspects of this case. That concludes the presentation, so Ambika, I'll turn it over to you.
Excellent. Thank you so much. It's so important to share that analysis with us. Very specifically, the difference between sliding scale insulin and correction doses. I think that's a transition that a lot of sites are making. And so it's really important to understand our use of electronic prescribing and the forms that we use to clearly communicate that intent. And I really liked hearing that the incident was, analyzed within the site, but then it was shared more broadly throughout the province and then now nationally through the Med Safety Exchange. So thank you for that. I'd now like to invite our second speaker from CIHI, the Canadian Institute for Health Information, to give us an overview of the much anticipated report on opioid-related harms in Canada.
So thank you, Ambika. My name is Roger, and I am a program lead in the opioid reporting team at CIHI, Canadian Institute for Health Information. And I'd like to thank ISMB Canada for the opportunity to come here to share about the opioid-related harms in Canada. I'd also like to say hello to my CIHI colleagues in the Ottawa office and in the Toronto office as well. My colleagues in the opioid reporting team as well. We all were involved in putting this report together, opioid-related harms in Canada. So in the next 12 minutes or so, this is an outline of what we're going to talk about. First, just a very quick introduction about CIHI, in case you're unfamiliar with our organization. And then we're going to talk about the report, the opioid-related harms in Canada, share with you some highlights from it. We'll have an overview of that report, and then speak about some of the methodological issues or aspects of it, and then finally share some of the results of the key findings, both from the hospitalization point of view and from the ED visits point of view. And with that, we'll conclude this part of the webinar. So about CIHI, we're Canadian Institute for Health Information, and our mandate is to deliver comparable and actionable information to accelerate improvements in healthcare, health system performance, and population health across the continuum of care. And some of the goals that we have in achieving this mandate include be a trusted source of standards and quality data, to expand analytical tools to support our stakeholders in the measurement of their health systems, and finally to produce actionable analysis and accelerate its adoption. So certainly this opioid-related harms in Canada report is part of this goal here, to produce actionable analysis. So we have 27 databases of comparable health information, ranging from topics such as health spending, health workforce, pharmacy, drug claims, medication incidents, for example. So these are some of our data holding. And in fact, this analysis draws from data from 3 of our data holdings, the HMDB, NACRS, as well as OMERS. I will talk about them in a little bit more detail later on. So let's talk about the opioid-related harms in Canada and share with you some highlights. And an overview, this is not our first release in this topic, opioid-related harms. This is, in fact, our 4th release from 2016. And this particular release was released in December 2018, so it's relatively recent. It is a chart book, so it is not like a long report with words, but it is a package with a lot of different charts and infographics and with short comments with them. So hopefully you'll find them quite user-friendly to go through. For those who wanted more data and more detailed information, there are Excel data tables as well, and both of these are available for download free of charge in our website, www.cihi.ca. So you can go to our website, and then there's a search box. If you type in opioid, then you will be directed to a page where this report will be there, as well as other helpful information. So for this analysis, it contains a number of analyses by province, territory, age group, sex, intention. And what's new in this release compared to our previous release is that we've included information for 4 types of opioid harm. In the past, we've focused on opioid poisoning, hospitalizations, and ED visits. But this time, we've expanded the definition of harm or the scope of harm to include 4 types of opioid harm. And in addition to that, we have also expanded a local level analysis as well. So let's go through this one at a time. Some of the methodology highlights. As I mentioned, this analysis included 4 different types of harm: opioid poisoning, which is some of the more acute event or the more visible event. But then we've also included, in addition to that, opioid use disorder, adverse drug reactions, and neonatal withdrawal symptoms. And I'll talk about the definition of them in more detail later. But these cases were being pulled out of the databases using ICD-10 codes. This analysis included 5 years of data from 2013 to 2017, and as I've mentioned, it drew from 3 of the CIHI's data holdings. Hospital Morbidity Database, or HMDB. This includes hospitalization cases. NACRS, which is National Ambulatory Care Reporting System, this database has ED visits data. And also, finally, OMERS, the Ontario Mental Health Reporting System. So we included some of the additional cases of opioid use disorder from this database. So let's talk about the results, and let's talk about the hospitalizations first, and then after that we'll talk about the ED visits. And for hospitalizations, what I'll do is I will first share the national data, share the big picture, and then in successive slides, I will drill deeper and deeper into the local analysis, going from national data to province and territory breakdown, to community size breakdown, to census metropolitan area, the bigger community breakdown, and finally to the smaller communities, the CSD, census subdivision breakdown. So with that, let's take a look at the national data. And what we could see here in terms of opioid poisoning hospitalization, 2013 to 2017, we see a stable increase in terms of opioid poisoning hospitalization. In 2017, there is more than 6,000 hospitalizations due to opioid poisoning, and the rate per 100,000 population is also increasing accordingly, with 16.4. Hospitalizations per 100,000 population in 2017. And when you look at from 2016 to 2017, there is an 8% increase in the rate of opioid poisoning hospitalizations. So that's the national picture. How about province and territory breakdown? And this is the breakdown here. And we could see in terms of a general trend, the northern and western regions of Canada continue to have the highest rates of opioid poisoning hospitalizations. And in terms of the change between 2016 and 2017, we see that rates have increased in Newfoundland, Labrador, Ontario, Manitoba, and BC, while the other provinces saw a decrease in rates. So that's basically the general picture, provincial and territory-wise. Now on to the more detailed local level analysis, and this one is the first one. It is the rates of hospitalization due to opioid poisoning broken down by community size. And when you look at this one, you could see that the community size of 50 to 100,000, 50,000 to 100,000 basically, have the highest rate of opioid poisoning hospitalizations. And in fact, the largest communities, the ones with a population size of 500,000 or more, have the lowest rate. So this is certainly a finding that's surprising, at least to me, because I used to think that the opioid crisis is a big city problem affecting big cities. But this analysis showed us that opioid poisoning hospitalizations affect smaller communities as well as bigger communities. And in fact, it might be more so with the smaller communities. Continue to drill down into the local level analysis. We have the opioid poisoning hospitalization rates by CMA, or census metropolitan areas. These are the bigger community, and this is 2017 data. And as we could see here, the bigger circle represents the higher rates. And as we could see among the higher rates of CMA, we see Kelowna, Thunder Bay, and Brantford are among the higher rates in Canada with respect to opioid poisoning hospitalizations. And finally, let's take it to the smaller community sizes level with the CSD, census subdivision level. These are the municipality, basically. And we could see that these are the 15 communities with the highest rate of opioid poisoning hospitalization. And among those, Nanaimo, Prince George, City of Kelowna, City of Brantford, Kamloops, so on and so forth. These communities have higher rates of hospitalizations that way. And I would encourage you to refer to our full report and the data tables because a full list of census subdivision is included in the report and in the data tables. Okay, so that's the expanded local level analysis. And now let's talk about the other thing that we've done that's new for this release, which is the expanded scope of opioid-related harm that we've included. So as I've mentioned, in the past, we've focused on the opioid poisoning, which is certainly like an acute event and a very visible and perhaps the most severe event associated with opioid-related harm. It occurs when an opioid is taken incorrectly, and that results in harm. In this release, we've also included adverse drug reaction, which is basically when the person has taken the opioid as directed, exactly in its correct way, and it still resulted in harm. So that's adverse drug reaction, and that's contrast with opioid poisoning. We have also included opioid use disorder, and in contrast to opioid poisoning, which is acute event, opioid use disorder is a relatively chronic event, including a wide variety of mental health and behavioral disorder that are attributable to the use of opioids. And finally, we have neonatal withdrawal symptoms, which occurs basically when a pregnant mom basically is taking opioids, and so the fetus is being exposed to opioids in utero. And when the baby is born, that supply of opioids suddenly gets cut off, and now the baby suffers from withdrawal symptoms. And so that's what neonatal withdrawal symptoms are. So in the next slide here, we could see the trends of 3 of the types of harm. We couldn't include neonatal withdrawal symptoms in the same graph because it uses a different denominator, because it only happens to babies. So I refer you to the full report for that finding or for that trends there. But we have the other 3 types of harm in this graph: opioid poisoning, opioid use disorder, and adverse drug reaction. For opioid poisoning, it is the dark line, the black line there, and we've seen this line before in the national numbers earlier, but yet we saw a stable increase in rates in hospitalization. In terms of opioid use disorder, that is the green dashed line, and we also see significant increases with opioid use disorder hospitalizations over the year of 2013 to 2017. And finally, for adverse drug reaction, that is the situation where the opioid is used properly, but it still resulted in harm. It had a high rate in 2013, but then there has been a decreasing trend over this 5-year period. So that's a hospitalization picture for opioid-related harms. Now let's take a look at the ED visits due to opioid poisoning. And for ED visits, we have Ontario data, we have Alberta data, and we have Yukon. These are the 3 jurisdictions that have submitted data of sufficient detail for this analysis. So the Ontario is the dark green line there, and the Alberta is the green dash line, and Yukon is the dotted purple line. And as we could see, over the past 5 years, ED visits have increased significantly in all 3 of these jurisdictions. And between 2016 and 2017, just that 1-year period, the rates of ED visits in Ontario increased 73%, and for Alberta, it increased 23%. So Ontario has a higher rate of increase. However, it is also important to bear in mind when you look at the green line compared to the green dash line compared to the dark green line, that Alberta has the higher rate. So again, Alberta has the higher rate, but Ontario has the higher rate of increase in that year 2016-2017. And I would urge caution to exercise caution in interpreting the data from Yukon territory because of small numbers. As you could see, there is quite a bit of fluctuation over the years. So I think that's all I wanted to share during this time period. In conclusion, for the first time in this release, that CIHI included information on 4 types of opioid harm, as well as an expanded local level of analysis. And together, hopefully, it provides a more comprehensive and also in-depth view of opioid-related harms across Canada. And when we look at the harms due to opioid poisoning, whether we're talking about hospitalization or ED visits, there is an increasing trend over the past 5 years. We also see in the expanded local level analysis that opioid poisoning impact small and suburban communities across Canada in addition to large urban centers. So both small and bigger and large communities are affected. And finally, with the types of harm that we included poisoning, which are the most serious and visible harms from opioid misuse. However, other opioid-related harms that require medical attention could include the mental health diagnoses, opioid use disorder, adverse drug reactions, and neonatal withdrawal symptoms. So I hope this presentation has whet your appetite for more. If you wanted to look at the full report, again, it's very user-friendly. Come to our website. The link is provided, or just go to www.cihi.ca and type in the search term opioid in the search box. So thank you very much, and I'll pass the time back to Ambika.
Excellent. Thank you, Roger. These types of analyses are important for us to recognize the seriousness of the opioid problem and how it permeates regions throughout Canada. We will now get into the observatory for some quick med safety updates. Our next speaker will describe the educational support for the ADR-MDI reporting that's mandated by Vanessa's Law.
Thanks, Ambika. Good afternoon, good morning, everyone. Just a quick check. Can you hear me okay?
Yes, we can.
Great, thanks, Ambika. My name is Mike Cass. I'm a Senior Program Manager at CPSI. Delighted to have this opportunity to share a little bit about the work we're doing with ISMP and HSO and Vanessa's Law. Here we go. So Protecting Canadians from Unsafe Drug Act, the other name for Vanessa's Law. This is legislation which strengthens regulations compelling acute care hospitals and other hospitals to report serious adverse drug reactions and medical device incidents to Health Canada. The purpose of this law is to improve Health Canada's ability to collect post-market safety information on drugs and medical devices, take appropriate action where a serious health risk is identified, and to promote greater confidence in the oversight of therapeutic products by increasing the transparency in this process. And as most of you are aware, this law was named after Vanessa Young, who died as a result of a arrhythmia while taking cisapride. So the Institute for Safe Medication Practices Canada is in a joint venture with Health Standards Organization and the Canadian Patient Safety Institute. And together, the joint venture partners were awarded a contract to assist Health Canada with the outreach, education, and feedback required to support the rollout of this law and the reporting that it requires. The joint ventures are working diligently with Health Canada to develop an educational content and approach that will enable participants, both public and provider, to understand the implications of the law, how to report, when to report, and so forth. The education is being designed to be easily integrated into existing educational activities, courses, and programs that are already provided by stakeholders, including the general public, and we anticipate that this will be available by July 2019. Pilot testing is beginning very soon, and we welcome you to contact info@ismpcanada.ca if you're interested in participating in this pilot. A little bit now on some of our other work. CPSI is also supporting and promoting petitioning to Health Canada to support consistent plain language labeling regulations for non-prescription medication. We have an e-petition that we are circulating, and we would be delighted if you would take the time to visit our website to learn more at www.patientsafetyinstitute.ca/petition. And last but not least, the Canadian Patient Safety Institute are launching 3 new safety improvement projects. These are 18-month learning collaboratives based on principles of knowledge translation and implementation science, focusing on 3 specific areas of harm. One project will focus on teamwork and communication and cover the Team Steps curriculum to improve communication. The second project will be medication safety at care transition, looking at reducing inappropriate prescriptions, deprescribing, and care of frail elderly. And the third is based on Enhanced Recovery Canada and techniques to promote faster recovery after surgery. We invite you to visit our website and register for one of our information webinars. These will be happening on Tuesday, February the 5th and Tuesday, February the 12th at 12 p.m. Eastern Time. And with that, I think it's back to you, Ambika.
Great, thank you, Mike. So just for everybody on the line, it looks like we're able to get into our discussion a little bit earlier. So I want to thank all our speakers for the excellent learning shared today. And so we have been receiving some questions. We'll try to get through as many as possible. Mike, would you like to take it away?
Thanks, Ambika, and thanks to all the presenters today. The first few will be directed to Amanda in PEI about the insulin sliding scale orders. I think the first two questions we received are somewhat related, so I'll ask them both together, and then you can answer them. The first one is conditional orders like correction doses or sliding scales and warfarin scales are often frequently subject to misinterpretation. Did you do any end user or usability studies with the new CPOE or new forms to ensure that most users will interpret it appropriately? And, is that possible in your organization? And the second question is, this is a good example of designing forms or interfaces for different populations. On one side, it's the healthcare practitioner. On the other side, it's the patient. Combining the correction and prandial doses into one single dose or one single number is certainly easier for the patient. But as we've seen in your case, it can be interpreted incorrectly by the healthcare provider. Is there any thought to patient and clinicians co-designing a form or an interface that would work well or suit the needs of both of them? Amanda?
Hi, thank you for those questions. I can comment that there was a multidisciplinary group that was certainly involved with the planning and implementation of correction dosing in our CPOE system in acute care. I'm not certain whether there was patient representation on that committee, but I certainly think that would be a good suggestion to bring forward, and the concept of end user studies to test whether the forms and workflow is being or interpreted correctly is a great suggestion, which I'll bring forward. Thank you.
Thank you. And a couple more questions related to that. It's more related to doing a BPMH when correction or sliding scales are used. There are many more patients nowadays on customized scales for things like insulin and even Coumadin, warfarin, and even often Lasix as well. And this person in particular often has a difficult time sorting it out if it's either sort of a direct dosing chart or if it's sort of an additional amount of drug. And they need to spend a lot of time with the patients and families to ensure that it's correct. Is this something you experience in your organization, and do you or anyone else have any thoughts about that?
Yes, I do have experience with that, and I can agree that it does take some time to sort out some of those specific medications that you mentioned. And as well as we know, when recording the BPMH, it's so important to record exactly how the patient is taking the medication. So the opposite side of that, though, is we have to make sure that information is interpreted correctly for our inpatient caregivers. So it is a challenge. I don't have an answer to it. One of the things that we were considering around this case, and we haven't ruled it out yet, is whether or not some sort of therapeutic interchange may be helpful with these customized correction scales. And that would thereby, reduce potentially some of the potential for error. At the end of the day, though, with the BPMH, we do need to record what the patient is taking at home. So it's certainly something that's not easy to work through.
And related to that, and this is sort of a challenging question for you, this person wishes to know what instructions the patient went home with, and sort of how did you ensure that the patient understood what to take back in the home, but also balancing that with ensuring that if he or she went to another hospital or another healthcare provider, the same problem wouldn't occur.
So a couple of things. We know that the Diabetes Education Center did update their process and the way that correction scales are documented on forms. with respect to the specific case, I don't know what the patient would have gone home with, but I can say generally speaking, we do have correction scale templates sort of built into the system, and those are to be printed off. If the patient's regime doesn't match the low, medium, high templates, then they would be transcribed into a blank template and provided as a hard copy to the patient, and that would be reviewed at the time of discharge.
Great. Thanks so much, Amanda. And we'll throw a couple questions now over in Roger's direction. Roger, we've had a couple of inquiries come up about what exactly ICD-10 codes are and DSM codes, and if you could explain that quickly and then move on to a few of these questions. The first one being, do you have a sense of what age groups are impacted most by opioid poisonings or the other harms? Is it mainly elderly with polypharmacy and comorbidities, or is this representative more of younger population?
Right. So, thanks for the question, and perhaps I could first quickly comment on the ICD-10 and DSM. So the ICD-10 code it stands for International Statistical Classification of Diseases and Related Health Problems. So basically, it is a classification system for disease which facilitates research in different disease states. So, like each of the disease or conditions would be associated with a code. For example, opioid poisoning, it's like a T40 code. I think the codes really isn't as important in this context, but it is a classification system for disease states that allow a systematic analysis or a consistent analysis of in definition and diagnosis. And for DSM, it is a clinical oriented classification of specifically for mental health disease states. So I think I'll leave it at that. In terms of the age group, we do have analysis with the age group in this release. It is available in the full report. So we see in terms of age group, let me take a look. 45 to 64 age group has the highest rate of opioid poisoning hospitalization in 2017. However, if you look at the rate of growth in that time period of 2013 to 2017, it is the younger age group, the 25 to 44 age group, which had the higher rate of growth.
Thanks, Roger. A few other follow-up questions. There are many more naloxone kit programs in Canada recently. Is there some way to track or triangulate naloxone use in Canada versus your findings? And in particular, does naloxone use coincide with these high-risk and high-rate communities?
Right. This is a good question. Like we haven't had a release in the use of naloxone so far, but this is certainly something that is interesting and to explore in the future.
Is your analysis able to discriminate between inadvertent illicit poisonings? And the sort of example given was I was looking to get high and accidentally took too much, versus accidental poisoning such as I forgot to take off my previous fentanyl patch and put a second one on and develop some harm related to that. And then thirdly, purposeful poisoning such as suicide attempts. And the follow-up is here, it strikes me that quite different approaches are needed in each of these scenarios.
Yeah, I agree with you. Quite different approaches are needed. And in terms of whether we're able to tease out these different types of intentions of poisoning, I think the answer is yes and no. Like we are unable to, our data does not have the granularity for us to look at whether a poisoning is illicit opioid or it's a prescription opioid. So we are unable to tease out this. However, like in terms of whether a poisoning is accidental or whether it's intentional, yes, and we did that analysis in this release as well. And what we found is 58% of the opioid poisoning are accidental in nature, and 30% are intentional in nature, and the remaining 12% it is of unknown nature. So they didn't really know what happened there.
All right, I have two more questions, actually three more, but two are related, so I'll ask them together. There's some evidence that opioid prescribing is actually decreasing in Canada, yet clearly the harms continue to rise. Is this indicative of perhaps more synthetic or adulterated or smuggled opioid products? And are you able to tell whether or not this represents sort of pharmaceutical opioids or heroin or other sorts of sources of opioids?
Right. So we also realized that, because we also did an opioid prescribing analysis, which was released earlier in 2018, and it did show a decrease in opioid prescribing. This opioid-related harms report, as I mentioned earlier, did not distinguish between opioid poisoning caused by illicit drug use compared to prescribed drugs. So the source of the opioid involved in the poisoning were unable to tell. So would it be an implication that looking at the opioid harms overall, including both illicit and prescribed opioid going up, and also in conjunction with the findings that opioid prescribing itself seems to have going down, does that imply that these harms are more due to illicit opioids? I suppose it is a reasonable hypothesis. However, we haven't looked at this directly because our data does not allow us to ask this specific question. And the next question in terms of the types of opioid involved, because the focus of this particular analysis is on the expanded scope of harm as well as the expanded level of local analysis, we haven't included the separation of different types of opioids in here. However, we did look at the opioid harms in relation to different opioid types in previous analysis that we've done.
And finally, Roger, has CIHI had success with knowledge translation of the report, particularly in communities that are sort of outliers in relation to these results, and what sort of engagement with the local and maybe broader health system leaders do you have? So there are a number of ways that we try to engage different communities with the information, like our website contains the report and also web stories that would hopefully engage the public. After the report is released, there is a media social media as well as a media session where we're engaged with in radio shows or a newspaper, and hopefully that would also spread the message to different communities. And in fact, we were interviewed by quite a significant number of communities where the rates were higher. Thanks. Thank you, Roger. We'll turn our attention to a few questions about Vanessa's Law pilot, and I'll ask Ambika, sitting beside me, to answer one in respect of time. Ambika, can you give a brief sketch of what exactly the Vanessa's Law pilot entails, and what are the timelines for implementation of the law, and when do we begin to report?
Okay, great. Thank you, Mike. So in terms of the Vanessa's Law pilot, so it won't necessarily be a pilot of Vanessa's Law, but it will be piloting the educational materials that the joint venture partners do create. So it would essentially be, going through the educational modules. Is it accessible? Was it easy to use? Things like that. So if you are interested in being part of that, please reach out to us. And the email address that's actually on the slides. And in terms of the timeline for reporting, so the Vanessa's Law is actually going to be, they expect that the final regulations will be published in June of this year, so June 2019. So that 6-month coming into force period will be June to December 2019. So we are looking at, mandatory reporting happening later this year. Okay, so I think that's all the time we have. Thank you, everyone, for your questions. If there were any questions that we weren't able to address verbally, we will be reaching out to you via email. So we do want everyone to be part of the Med Safety Exchange, so whether it's an incident analysis or a Med Safety initiative, please email us to share the learning, and please don't forget to fill out the poll that has been on your right-hand panel there, because we really want to know, what your needs are and how we can better meet them. And the registration for the next webinar is available on the website, so please head over there now, and we will see you again in 2 months. Thank you, and bye for now.